Hi friends, I'm going to be talking all about PRP. Maybe you've had it in the past and it hasn't worked so well. What exactly is PRP and what's the latest research saying? Before I start, you may note that my eyes look a little bit weird. One is much bigger than the other. That's because I went to go and see a couple of my pals who are ophthalmologists and I had some drops put in. But I was so desperate to bring this video to you today, I just thought, what the heck, let me film it. So the first thing to note is that PRP research has been a little bit sketchy. And the reason for that is because there isn't one standardized method of making PRP, which makes it very, very difficult to compare clinical studies. In the past, PRP was considered to be a platelet count that is just higher than you would naturally have within the body. That then evolved to become something which was greater than 1 × 10⁶ microliters, or approximately 5 times the baseline of platelets. You will see that different PRP or PRF devices will concentrate your platelets in different amounts. So you can see the problem here. In a paper published 3 years ago, they had all kinds of concentrations of PRP, all the way through from cell-fill, which was 0.52, all the way up to the M-Site Genesis Pure PRP2, which had the aforementioned concentration. So you're going to have 2 different types of PRP maker. The first type is something like the Magellan or the Angel, which is a continuous flow centrifuge. So basically the blood gets pushed in slowly over time, and as the bowl continues to spin, separates it on that basis according to the weight. You'll need much more blood if you're going to use a method like this. Normally you'll take a unit. The other type uses a rotational centrifuge, so you put all the blood in one go and then you spin the tubes around and the blood separates because of the gravitational forces. The vast majority of commercially available PRP machines are the second type, so the rotational ones. You may have heard the different terms PRP and PRF. Generally speaking, PRP uses an anticoagulant and a centrifuge. PRF doesn't use an anticoagulant, but it does still use a centrifuge. If you leave the PRF long enough without the anticoagulant, it eventually turns into a jelly-like substance or a fibrin clot. You can then go on to mush this up and inject this back into whatever it is that you're trying to treat. So say you're treating the face, you can inject this into the skin, and the idea is that it will act like a sort of scaffold, a chemotactic pathway, if you like. It is said that the PRF will provide a longer and more sustained release of growth factors than PRP. I haven't seen any evidence of this in my research. Just for brevity, for the remainder of the video, I'm going to use the term PRP just to describe any of these technologies. We have 2 different types at the clinic. So we have the Angel system, which is the type of device I mentioned first, so the bowl type centrifuge, and then we have also the Arthrex and the Regen system, which are the traditional gravitational centrifuges. The reason we have the 2 is because the Regen has the type of test tube that you can easily combine the PRP with hyaluronic acid and make a mixture like that. You don't have to manually do it yourself. And there's also a very easy method of making fibrin as well. You can do these things, of course, with the Arthrex, but it's not quite so straightforward, and the Arthrex was bought first. So what's the whole point of PRP? The idea is that the platelets will release many biologically active factors when you inject them back into the skin. I'm talking about growth factors, cytokines, lysosomes, and they also have these adhesion proteins that are responsible for initiating the hemostatic cascade, synthesis of new connective tissue, and revascularization of the area. There are plasma proteins such as fibrinogen, prothrombin, fibronectin in the platelet poor plasma fraction. So actually, I know it sounds like, oh, platelet poor plasma fraction, why would you want that? Well, actually, you do want that as well. The idea is that PRP concentrates can jumpstart the supraphysiological release of growth factors in the body. So they make you also release more of your own growth factors when you inject them. PRP is as complex as blood itself is, and it's much too complex for a simple soul like me to understand. That's why they have special doctors called hematologists whose job it is to just look at the blood. It's not as simple as something like hyaluronic acid, for example, which can only differ in the chain length or the cross-linking agent that's used or the source of it. PRP is an insanely nuanced and complicated topic. You may be thinking, okay, well, I had PRP and it didn't work. What's up with that? Why didn't it work? Well, it depends what you had it done for. So there's a lot of evidence for the use of PRP in different types of alopecia and also in orthopedics. There's less evidence for it when it comes to things like skin rejuvenation. As I previously alluded to, the fact that there are so many different concentrations possible with PRP when you spin the blood means it's really difficult to say just across the board, oh yeah, PRP works or PRP doesn't work. It's a bit tricky. And actually, if you have too much growth factor concentration, so it's too concentrated, it works less. It's thought that this is because the number of cell membrane receptors is limited. In this paper, it shows that in order to stimulate an antiangiogenic response and cell proliferation, you need to have at least 7.5 times 10 to the 9 platelets in a 5 ml vial. Do you know how many platelets were in your PRP when you had it injected? Do you also know how many red blood cells you had in your PRP when you had it injected? Probably not. Why is this relevant? Well, it's because when you inject a lot of red blood cells, you get this thing called eryptosis, which is the release of a potent cytokine, macrophage migration inhibitory factor, and it's very, very pro-inflammatory. It inhibits the migration of stem cells and also inhibits fibroblast proliferation. You don't want that. So we have to minimize the red blood cells in PRP. Which is funny because in most of the media that, well, years ago that you used to see, so do you remember that picture of Kim Kardashian when she had blood all over her face? That is definitely not what you want when you have PRP. Interestingly, you can actually change the percentage of leukocytes in PRP. So, well, you can if you're using a system like the Angel or the Magellan, because if you're doing a hair preparation, then you want to have a little bit more leukocytes than you would if you're doing the skin. You can actually test before you inject PRP what's in it, what's in the stuff that you've got. You can get these platelet counters. They're not crazy expensive. Disclaimer, I do not have one right now. I am looking at getting one. I just think it's good practice to be able to say, you know, in this case, we know that we had X number of platelets and Y number of leukocytes before we perform the treatment. Oh, isn't it interesting the next time you see that patient, they had different percentages. And I don't think that's the industry standard, but I feel like it probably should be. So you had PRP, it didn't work. Maybe it's due to the platelet concentration, as I've just mentioned, but maybe there are other factors as well. So how can you maximize the effect of your PRP when you have it done? The first thing you can't really change is your age. So unfortunately, as you get older, you're going to have decreasing number of stem cells, which means that the PRP is not going to work as well. The next is drugs. I'm not talking about the illegal kind. I'm talking about aspirin, paracetamol, diclofenac, ibuprofen, naproxen, indomethacin. These drugs all had effects on the number of platelets. So if you are taking these drugs, it's best to have about a week of washout between you taking the last dose and doing your PRP treatment. That's if you can. Obviously, if you're taking it for a very compelling medical reason, PRP maybe is not the treatment for you. So, selective serotonin reuptake inhibitors, so SSRIs, antihistamines, some antibiotics, tricyclic antidepressants, they all suppress normal platelet function. Quinine also reduces platelet count. So if you're taking any of these drugs, it's not going to work as well for you. We all know stress is bad, but it also stops your PRP working as well. So stress induces a surge in adrenaline, noradrenaline, and serotonin, which increases the platelet sensitivity to thrombin, aggregation and factor release. Alcohol and tobacco decreases platelet activation. Diets containing caffeine, chocolate, quercetin, which is present in onions, apples, tea, wine, and isoflavones in legumes, all decrease platelet activation. Anthocyanins present in many fruits also decrease number of activated platelets. So your diet has an impact. Not only that, but patients who ate a high-fat meal also had a greater platelet harvest than those who were fasting at the time the blood was taken. And the optimum time of day to have the blood taken was in the afternoon. If you've got hypertension, this induces your platelets to already release their growth factors and also reduces platelet number. And also, if it's being used at the same time as lidocaine, and we all know if something's going to be a little bit sore, sometimes your injector might want to put some lidocaine in there first. That stops the platelet function. Interestingly, it should not be performed at the same time as botulinum toxin because it renders the botulinum toxin ineffective. So as you can see, there are all kinds of factors which will influence whether or not your PRP is going to be effective for you. And some of these are things that we can change, like for example your diet, what time of day you're having the treatment done, whether you've eaten something beforehand. But of course some of them you can't change, like your age or whether or not you've got hypertension. Uses of PRP. In a 2013 meta-analysis comprising of 555 individuals, it was found that PRP increased the density but not the diameter of each individual hair in patients with androgenic alopecia. Interestingly, it was found to be more effective in male patients. There really is very little downside to having a treatment with PRP. There are not really any risks, and aside from the financial implications and of course the element of discomfort during the procedure, there isn't really any issue with doing it even if it doesn't work for you. This 10-year-old paper has 45 participants included, and it was discovered that the PRP, at least in this group, had a bigger effect on the alopecia areata than intralesional steroid injections did, which is quite interesting. This even older paper from 2008 shows the effect of PRP on pain reduction after shoulder surgery. They found that the patients were in less pain after the procedure, they were using less opioid-based pain medication, and they also had more successful post-surgical rehabilitation. In another pain example, looking at patients who had neuropathic pain, which was secondary to nerve damage, it was found in this paper that the neuropathic pain remained eliminated or reduced for a minimum of 6 years after the procedure, which is a very long time if you're in pain. Now, the quality of the publications around PRP have been, as I mentioned before, quite patchy, particularly when it comes to pain. Some have been inconclusive, some positive, some negative. And as I mentioned before, this is probably because the authors sometimes don't publish their protocol, exactly how it is that they're injecting the PRP, which would be really helpful when it comes to making sensible comparisons. This is probably one of the things which AI actually will be helpful for over the longer term, because it will be able to more meaningfully sort through these papers and group them together accordingly. There is a little bit of weak evidence for its use in vitiligo and melasma, according to this review, but it doesn't seem like anything particularly compelling. The same paper also reports an improvement in inflammatory nail conditions like lichen planus when the PRP is used alongside a steroid for the nail. A little bit of weak data for psoriasis. A lot of data using PRP for wound healing and finding that overwhelmingly the results are positive. Along the same vein, you can also use PRP alongside a fat graft. So autologous fat grafting has got good results in the short term. Long term, it can be not so predictable, so you can have reabsorption of the fat of anywhere between about 20 and 80% of it will go away. The evidence for the inclusion of PRP in fat grafting has been pretty if you're going to have the fat grafting done anyway and your surgeon offers the facility to do it alongside PRP, and if it's not harmful, why not do it? When I had my fat grafting, I did not have PRP, but that's simply because it was not offered. If it had been offered and the surgeon had really believed in the technique, then I probably would have had it done. PRP is used quite extensively in dentistry, which is actually where I first heard about it. If you recall, I was a dentist before I did medicine, and it can be used for tissue growth in treating various gum diseases, regenerative endodontics, and also treating intrabony defects. For example, if you've got a hole in the bone and you want to put an implant in there. So although there are a lot of published studies outlining the use of PRP in dentistry, the problem there is still pretty much the same. Some are good results, some show no better effect using the PRP, but it's the same problem, they're using different types of PRP device and so on. So we really need some kind of standardization here. In orthopedics, PRP can be used for a ton of different things. For example, osteoarthritis, tendon injuries, lateral epicondylitis, patellar tendinopathy, Achilles tendinopathy or rupture, ligament reconstructions, plantar fasciitis, and muscle injuries. This review showed that PRP might have some benefit in patients who have knee osteoarthritis, lateral epicondylitis, and ulnar collateral ligament injury, whereas there's inconsistent or minimal evidence for it in other pathologies. It goes on to say that there's insufficient literature to support a consensus on the optimal PRP preparation for each indication, the volume used, the interval, and whether or not activation of the platelets is necessary, and if so, by what method. There's still not really much in the way of evidence-based medicine there. However, if you're one of the lucky people for whom it works, absolutely crack on, and there's no harm in trying it. So earlier in the video, I said that there was very little risk with PRP, which is true when you're injecting the scalp. However, there have been globally 4 cases of irreversible blindness reported after facial injections with PRP, which sounds completely how even does that happen, right? Well, it's because it could be injected inside of a blood vessel and it could act as a coagulant inside that blood vessel and cause a blood clot, which then, in the same way that filler would act, can then lodge in the retina and cause blindness. So it's not entirely without risk, but the risk is infinitesimally small. If you are having injections of PRP, I would follow the same protocol as you would with hyaluronic acid injections, and just be aware that it's not exactly completely risk-free. This is not the case, by the way, if you're having microneedling PRP. It's only if you're doing a deeper type of injection. So microneedling, nappage, mesotherapy, not going to happen. One thing that I just wanted to touch on really briefly is new advances in PRP. So I'm sure you've heard of exosomes by now. Exosomes can either be from human, animal, or plant derived basis. In Europe, we cannot use anything which is human derived, so we're left then with animal or plant. We also can't inject exosomes, so you're restricted to doing either a laser or a microneedling treatment and then applying them topically, or actually radiofrequency microneedling and then applying them topically. Interestingly, some of the newer radiofrequency microneedling devices are increasingly used more for drug delivery rather than the original purpose of radiofrequency microneedling, but that's a whole other video. There is something called exokines, which is an autologous product, so it's from yourself, which neatly circumvents the problem of not being able to use anything human derived. Basically, you can use something from yourself as long as you don't mess about with it too much, which is why PRP is allowed. These can be harvested either from fat or blood. Obviously, getting them from fat is a bit annoying, bit of a pain. Getting them from blood is easier, but still it's quite a faff. This is, by the way, one of the reasons why when you have a fat transfer, the skin tends to look better in that area that you've had the fat transfer to. And it's the basis behind why we would do a nanofat transfer. So even when you're not adding additional volume into their area, it's because you're taking all the stem cells with you. Anyway, both exosome and exokine technology have their own technical or regulatory issues. For the sake of simplicity and ease, if you want something or you need something which is to be injected rather than just a very surface treatment, at the moment, at least here, it's really the only way to go. And to be clear, this was not a video about exosomes or stem cells or fat transfer. I more wanted to focus on what you could do to improve the chance of the PRP working out for you, and to give a very broad overview of what you can actually do with it. I do think when it has been approved for us to be able to inject exosomes, and I think that the next generation of fillers will likely combine a hyaluronic acid maybe with an exosome. I think that will be a total game changer. So, in conclusion, yes, we do PRP in the clinic. We've got 3 different devices with which to perform PRP. I would say that the majority of treatments are for some type of alopecia or before or after a patient has a hair transplant. I will perform PRP with microneedling or injected PRP if after a conversation the patient prefers something which is autologous. I feel like it works particularly well if you are doing the fibrin for the under eye region. In somebody who's got extremely crepey skin in the under eye area, you cannot just go straight in and put hyaluronic acid there. It will look absolutely terrible. You're going to be able to see it. So you either have to do a course of treatment using something like polynucleotides or Sunacos or PRP, either with or without the hyaluronic acid or with or without the fibrin. And that's actually my favourite area to use it in. I think it's a very exciting field, all of regenerative medicine. What we really need to see, as I've said many times during the course of this video, is for some kind of consistency between the clinical trials so we can establish the best way to use this incredible resource. If you're watching from a country which doesn't have Sunacos and doesn't have polynucleotides for the eye, you're quite limited with what you can use in that area for skin conditioning. So I think there, PRP is a really powerful choice, particularly if you're doing it the fibrin way or combining it with hyaluronic acid. Well, I hope that was illuminating. Let me know if there's a topic you'd like me to do a deep dive into, and do not forget to subscribe. You don't want to miss anything.